Hola, hola, y bienvenidos a Tu Salud, the definitive podcast for Latine and Indigenous health policy, where we talk about all things Latine, policy, and our health. I am Dr. Ceci Aquino, Executive Director at the Latino Coalition for a Healthy California. And today I am joined by Mr. Anthony Wright, Executive Director at Health Access. Today we'll be talking about the power of public health, the battle wounds and celebrations in the health equity movement, and the careful balance of state and federal work as we advance health equity and health justice for our communities. With that, let's get started. Anthony, thank you so much for joining us today. Just to get us started, tell us a little bit more about yourself, your story, what makes you you.
Well, thank you, Cecia, for having me. I really have appreciated the partnership of my organization with Latino Coalition for a Healthy California and myself with you over the years, and so really happy to be here. My name is Anthony Wright. He, him. I am the executive director of Health Access California, the statewide healthcare consumer advocacy coalition, and my story, starts even though we're in California. It starts in the Bronx, New York. My mother is an immigrant from Ecuador. She is one of 17 children. Her father was actually from China. So we're
Mm,
a very large Chino Latino family in
yeah,
with a spreadsheet that has over 230 relatives
it's a whole network.
around the world. Um, she was one of the youngest of the 17 and came over and to New York City where she met my dad, who and so my background is I have four grandparents from four continents,
Wow.
uh, China, Ireland, Ecuador, and of course the United States. And so that one of those only in America, maybe even only in New
Yeah,
York kind of stories.
yeah.
Um, I we I grew up in the Bronx, and a lot of the origin story of the work that I do comes from the fact that I uh, was able to get, even though it was literally the poorest congressional district in the nation and had all
Hmm.
various issues.
Hmm.
It also had the opportunities of New York, and one of
Yeah.
those was a program that got smart inner city minority kids into scholarships into private high school.
Mm.
And so uh, for my um, for much of my high school, I went from one end of the Bronx
Hmm.
to Riverdale Country School, which where the tuition is tens of thousands of dollars, and got a great education,
Yeah.
and also got an education, a daily education in the inequities in our system, in our society, that some just and so I felt a real need to and calling to both give back to the community,
Hmm.
make something of the education that
Mm.
I had been granted, the privilege that I have. I talk about being from the Bronx
Mm.
and my background, not to say, oh, I woe is
Mhm.
me, I had it tough, but in fact, to recognize the privilege I have, that
Mhm.
including my education, and then what do I do with with
Yeah.
that privilege. And so, and through that program called Prep for Prep, I had an example of not just a mission but a means and a method
Yeah.
of doing of people devoting themselves in a not for profit but for people
Yeah.
to try to make things a little bit better.
Mhm.
And so that's how I get started in terms of healthcare. you know Part of my growing up, I was uninsured. My dad
Mm.
was did a variety of jobs and wasn't but was an HVAC
Mm.
technician,
Mhm.
um,
Mhm.
and but before he got that union job,
Mhm.
later in his career, there was a good parts of my time that I was uninsured myself. And
Yeah.
in fact, I remember having appendicitis in second grade and
Yeah.
going to the public hospital, Jacobi Hospital, um, for 2 weeks because there was complications, and I
Mm-hmm.
remember the stress that my family was under, and how much my parents were worried
Yeah.
for me, and
Yeah.
frankly worried about the bill and what
Yeah.
would happen, and how you dealt with that bill. And
Yeah.
I so it's a very visceral thing that I know that when people get something like a hospital bill,
Mm-hmm.
that is often the biggest bill they'll ever get in their entire life.
Yeah.
And so how can we provide uh, a better system in public policy so that people are not dealing with a surprise medical bill, or a
Right.
life changing hospital bill as a result. And so that so some of the work that I have done over the years is personal to me in that
Mm-hmm.
regard.
Mm-hmm.
Um, uh, I also recognize that there's a lot of things that is just this is just also about
Mm-hmm.
justice. And so there's
Yeah.
a lot of work that we do where it's not necessarily in my experience, but you also have a sense of, but that's you can still have the empathy of there, but for the grace
Right.
of God go I, that's not the way that the system should be working, and
Yeah.
that informs my advocacy today.
That's beautiful. Thank you for sharing. I love that New York and California, we have these parallels, right? Our communities are beautiful. We have this amazing representation and diversity in both states. And, there's these beautiful stories of growing up and developing that amazing, diverse community and growing up in that and being able to experience, like you said, many of the things that now we try to advance with our work in terms of health equity and health justice.
Yeah, no, and it's obviously the landscape of New York or the Bronx is different than California in some ways, but there's
Of course.
similarities, and there's lessons. I literally grew up on a block, with the Cross Bronx Expressway, which
Mm,
I didn't necessarily know it at the time, but if it's become an example of
yeah.
like structural, institutional inequity, or even racism.
Yeah.
There's a whole chapter in the book, "The Power Broker," by Robert Caro, about the construction
Yeah.
of the Cross Bronx Expressway by Robert Moses, and how it was built,
Yeah.
in both in terms of structurally, in order to how it they basically bulldozed and created
Mm-hmm.
what we now know as the South Bronx,
Yeah.
and the issues there, and now there's even talk about uh, maybe capping that highway and putting a park uh,
Right.
on that new land, rather than
Yeah.
something that's producing pollution,
Right.
and that's particular to my specific block and that specific area in the Bronx, but
Yeah.
it's not dissimilar to a story of why there is such asthma in the
Yeah.
Central Valley, or issues in Los Angeles, or
Exactly.
um, the variety of other structural and
Mm-hmm.
problematic issues that we see across the country, even. And
Agreed.
each story is particular, but there's universal, both issues that run through our history,
Mm-hmm.
and also potential solutions to
Exactly.
get us to a better place, whether it is the delivery of healthcare, or even in the work of just trying to make sure that folks are healthy to begin with.
Exactly. It's those structural and systemic changes that we're aiming for with the social determinants of health, right?
Mhm.
Yeah.
Right.
And I love that you highlighted this piece. And, we've been having amazing conversations with other Latina and Indigenous leaders. And a common pattern that comes up is this connection with pathway programs, be it a scholarship program, be it an internship, that gives us access to a system that perhaps we wouldn't have access to otherwise. And that makes a huge difference, not just in the individual level, but also to that family, that community, and ultimately the state, right? Because that investment in that child is now paying off with population health.
Yeah, I think, I mean, I highlighted the program Prep for Prep in New York because it was life changing.
Mm-hmm.
And if I were just, even though I have a mixed identity in lots of different ways,
Yeah.
including ethnically, um, I would say that being a Prep for Prep alumni is a core part of my identity and my story. It also is an important sense. It's not just a pathway, but it's also in some cases a community.
Mm-hmm.
And
Mm-hmm.
I want to highlight that when I went to the private high school, I was one of 3 Latino boys in the entire class, and the other 2 were also from the program
There you go.
that I came from.
Uh-huh.
Um, there was no Latina girls. There was,
Yeah.
to my chagrin, and there was, um, I mean, a handful of African American,
Mm.
students. 2 of them, one of them in my class was Diana Ross's daughter.
There you
So,
go.
and it was great to meet and to be friends with,
Yeah.
many of the folks in my class, but it was also useful to really have, like, that base of, and some of them are still my closest friends to this day, who have
Mm-hmm.
been through just the same experience,
Yeah.
and that is a bond that is forged of just
Yeah.
providing that kind of support. And so we don't do, those who walk sort of these paths don't do it alone.
Exactly.
um and it's and so it has been gratifying when I came to California, which again is 3,000 miles away from
Yeah.
um New York. It There was some comfort in that California also has that hyper diversity of,
Mm-hmm.
again, I grew up in a Puerto Rican and Black neighborhood,
Yeah.
but and there's not a lot of Ecuadorians in California,
Right.
but the fact that it was a sort of a hyper diverse population
Mm-hmm.
of from so many different places was
Yeah.
very comforting to me, and I was able to find community to support the work that we do.
Yeah. And I appreciate that you share working hand in hand with other communities of color, right? I think many of us are systemically disenfranchised, and it's by being in the same space, growing up, going to the same schools, right? Where we learn to have this partnership and recognize that many times our communities are pitted against each other for limited resources, right? But we're no longer in that space. And like you said, we're stronger together and we're able to advance the health equity movement because we're working hand in hand. So maybe
Yeah.
with that
I,
in mind, can we talk about, your work with Health for All and how that movement really came from working hand in hand with other communities of color and other systemically disenfranchised communities?
well, before I get there, I do want to
Yeah.
emphasize the point that you just said. Right, is that um, one of the first sort of campaigns I ran was actually in college. I was the
Mm-hmm.
co-chair of La Causa, the Latino students organization at Amherst College, when Amherst was um, considering abandoning its need-blind admissions policy,
Mm-hmm.
and so that was a time where I helped organize the campaign to sort of push back on that. There's a lot of talk about campus activism these
That's
days,
great.
and that was a very deliberate coalition approach that included the Black Students Union and the Asian
Mm-hmm.
American Association, and a variety of other uh, student organizations.
Yeah.
And we built a campaign and
Love that.
tactics and strategy, and to protest the board of trustees decision and get a reversal of that. And
Mm-hmm.
to this day, that college is now actually one of the leaders in providing financial aid and need blind admissions, and has really made it part of its identity. And so
That's
that's a point of
powerful.
pride. So that gave that gave me both an early lesson that kind of
Mhm.
cross-cultural coalition, how
Yes.
important that is,
Yes.
that this is not about a specific issue. This is about banding together uh, a broad set of interests on behalf of a broad principle that then specifically helps Latino and Black
Right.
and frankly um,
All of
the
us.
student body as a whole,
Mhm.
because that made it
Mhm.
and so that gave me some lessons. It also gave me some confidence that, hey,
Yeah.
this is maybe uh, something I could do, not just as a side but as a career.
Yeah.
um, and so that's and that led to doing some work in New Jersey and in
Mhm.
Washington D.C. uh, before coming to California and becoming and being part of Health Access for now the last 23 years. Um,
That's quite the
you meant
legacy.
what?
That's quite the legacy.
Right. No, it
Congratulations.
was the
Yeah.
first time I got quoted in the New York Times. It was the first. It
That's
was. I was proud of that. But then and then um, you know I got into healthcare. Working for New Jersey Citizen Action, doing a variety of campaigns there.
Mhm. Mhm.
I moved with my wife to California and was able to join Health Access, which was already a good and important and established organization,
Yeah.
and was part of many campaigns there. And Health Access by itself is structured as a coalition organization, in
Mhm.
its board and governance, and in it and in all the work that it does, because we recognize that when you're going against funded industry opponents,
Mhm.
um, uh, you you may not have the power of the purse, but you can potentially
Yeah.
get the power of the people if
Right.
you can build a broad enough coalition of i- uh, of of constituencies and communities together.
Mhm.
And I think that was, very proud of the work that we've done to implement and improve the Affordable Care Act.
Mhm.
And
Mhm.
um, while we were and we're very active in that effort, but while
Yeah.
also being wide-eyed about
Yep.
what it was missing
Yes.
and what was left to do. And so when it did pass uh, in 2010,
Mhm.
and California then started the work of, okay, are we going to expanding Medicaid to,
Yeah.
under the Affordable Care Act? It was pretty clear that we were expanding these programs, but that were universal. Like,
Yeah.
we are now going to expand Medicaid to everybody, regardless of to everybody under 138%. We were going
Mhm.
to now provide subsidies to people above 138% to buy private coverage, but
Right.
there was this big asterisk, which
Yeah.
was that we are going to exclude based on immigration status, and that's something that was not aligned with California values. It doesn't
Mhm.
make sense from a healthcare point of view. People
Mhm.
like um, we our system is stronger when everybody is included, and
Yes.
diseases don't discriminate,
Yeah.
and people uh, and we are all dependent on the health of each other.
Mhm.
And that was something we knew before the pandemic, but is now
Yeah.
doubly underlined now.
Oh yeah.
And so it was really important to have bring together the coalition that supported the ACA in all of its
Mhm.
diversity, and
Mhm.
say this also needs to be a priority to do
Yeah.
that unfinished work of filling in the gaps. And this is the biggest and most obvious exclusion here.
Yeah.
And it was something that I will also say was very deliberate when we were starting the Health for All campaign. We did this in co-leadership with the
Mhm.
California Immigrant Policy Center,
Right.
because we know we needed those with lived experiences to be on the front
Mhm.
lines of talking about the issue.
Yes.
Um, I think it was a really great combination of the health reform movement and the momentum that we had had with the Affordable Care Act and the
Mhm.
immigrant rights movement, and the great work that the immigrant rights movement had been doing,
Right.
with regard to getting acceptance in other parts of
Mhm.
society and law, driver's license, professional licenses, the Trust
Right.
Act, etc. And and to combine and to have a combined um, power of both of those movements, even
Yeah.
though both movements were a little bit different in their skills. Like one was a little bit more
Mm.
um, uh, policy nerdy. One was a little bit more militant. One was,
Mhm.
and so, but that creative tension has actually been positive
Yeah.
for getting the work done, and having complementary messages of both the message that immigrants are an important part of our society and economy and should be fully included in our health system as
Yeah.
well, and the message that health access and others will continue to say, which is that our health system is stronger when everybody is included, and
Yeah.
that's a benefit to our health, to the health of the individual, of their
Mhm.
family, and the community. That's a benefit to the economy and to
Yes.
the specific finances of the individual, the family, and the community.
Yes.
It's a benefit to the health system that we all
Yes.
rely on, and so that's why the coalition approach has been like so crucial to our work,
Yeah.
because a that's how you that's how you win, but also that's how you win in the most equitable
Yes.
and effective way possible.
Yes. I couldn't agree more. And, I think we're so privileged to live in California and to say that California is really leading the nation in this health equity work, right? I think we're setting an example for the rest of the nation to follow. And that's extremely powerful. I want to dig deeper. You mentioned how different skill sets are needed, right? And different organizations, different stakeholders bring those different skill sets to the table. I wonder if you can share a little bit more, about this over a decade time that happened in terms of moving the Health for All campaign forward in, sections, right? And just about what skill sets were needed as we continue to advance step by step, and how our government officials, both elected and administrative folks, were also needed and were working hand in hand with us to advance that work.
Yeah, I mean, I don't think there's an either or. I think as we have expanded Medicaid and gotten rid of the exclusion based on immigration status, even as we continue to do the work to open up covered California as well,
Yeah,
there's been some talk about how do you document and what made the difference to get us here,
right.
and some may say it's the grassroots organizing, some may say it's the storytelling, some may say it's the really important
Mm-hmm.
academic research and work about to figure out the financing and
Mm-hmm.
try to to recognize how much it costs or how much it doesn't cost or what the
Right.
offsetting savings are, those kinds of things.
Right.
Sometimes it's because of our legislative champions, and sometimes it's because of the messaging and things, and external forces like
Mm-hmm.
uh, whether it's the work around the ACA fight back or the pandemic or other
Yeah.
things that help create political moments. But in honestly, it's all of those things working
Right.
together in unison. Like legislative, you can't say enough about legislative champions
Right.
like State Senator, now Insurance Commissioner Ricardo Lara, like Assemblymember Rambula, like Senator Maria Elena Dorazo, that
Mm-hmm.
were able to take this campaign and move it forward in the legislature, and to
Mm-hmm.
use the growing power of the Latino caucus in the legislature, and frankly, not just in the spirit of what we've been talking about, not just
Yeah.
the Latino caucus, but the other caucuses and committed allies in the legislature to say,
Yes.
no, this is a priority toward this goal of getting to a health system for all.
Yeah.
Um, you can't say enough about the work of doing the policy work, and sometimes it gets fairly technical about trying to figure out,
Mm-hmm.
okay, because if you're going to do an expansion of coverage, you need to figure out like the details of how it's actually going to be
Right.
implemented and undergirded, and how much of a change it is, and how much of it is actually
Mm-hmm.
a relatively small part of a much bigger Medi-Cal program that
Yeah.
now covers like 14, 15 million Californians, need a third of the state. So what we're talking about is actually a
Yes.
relatively small percentage of a much, much bigger pie, and putting it in that context, and putting it in the context of a broader health reform agenda that includes providing greater affordability for all Californians, providing greater
Mhm.
access and eligibility for all Californians, and so
Mhm.
people, so that we're not doing this from a position of scarcity. We're not doing it
Yes.
that, oh, there's this population that's getting more. No, we're actually trying to make the health system more accessible for everybody,
Yes.
and this is a component of a larger strategy,
Yes.
and which is true here in California. I mean, at the same time that we're doing this, we're also providing greater affordability assistance in covered California, so that um, people have lower premiums and reduce cost sharing, and where we have a new Office of Healthcare Affordability to
Yeah.
try to even limit the costs that people are dealing with in private coverage. So this is part of a broader strategy, and
Yeah.
it's not just about this population here or that population there. Um, but I would say the thing that I would say is very core is the issue is
Mhm.
people telling their stories of their
Mhm.
experiences, and that's has to be, yeah, at the top of the list of,
Yeah.
because that has been so moving and so powerful over the years for people to talk
Yeah.
about how they're what happens when they don't have this primary preventive care.
Yeah.
What happens when folks are left um, to fall through the cracks of our healthcare system, and
Yeah.
how that benefits nobody, not
Mhm.
not the
Mhm.
individual, the family, but how that messes up, has redounding impacts on that family, on that community,
Yeah.
on the health system as a whole.
Yeah.
The fact that, right now, by covering these folks, now they're paying patients at the hospitals and the
Right.
clinics that we all rely on, and that's a really important message for folks to hear. And again, also just with regard to and there that those storytellers took some
Mhm.
bravery. In many
Mhm.
cases, they were undocumented,
Mhm.
um, and so maybe told their story with some risk.
Yeah.
But I think it was I can't say enough about that being a really important piece of
Yeah.
this, in addition to um, all the in addition to the coalition work and the
Right.
communications work and everything else.
I couldn't agree more. It's that people power, right? It's that magic of human connection when we are able to share our stories, and maybe it's not the same background or a very specific story that connects us, but it's that human touch, right? Listening about what you went through and what I went through, and being able to connect at that human level.
Yeah, and not just for themselves, but also for their family or community members. I mean, I think one of the
Mhm.
most powerful moments was, we had made the step to cover all children in 2016,
Mhm.
and there was a debate in our community about, like, okay,
Right.
if we're going to do this step by step, and
Yeah.
obviously we want to get to universal, but things
Of
take time
course.
and you need to do it in steps. What's next? And
Yeah.
there was a lot of logic about going with young adults,
Yeah.
because there was just a simple issue that a lot of the children that we were covering, once they turned 18, would
Right.
age out of coverage, and that's not a great happy birthday present for anybody.
Mm.
And so how do you just, like, incrementally raise that age limit? It
Right.
also made sense to align with the Affordable Care Act philosophy that people under up to age 26 should stay on their parents' coverage. But what if their parents don't have
Mhm.
coverage?
Mhm.
To parallel with that kind of policy.
Yeah.
But a lot of those folks, including, and a lot of those folks were the people that we were working with and talking
Yeah.
with, was like, well, we appreciate that, but I'm not in this for myself. I'm in this for my abuela. I'm in this
Right.
for my mom who needs, her
Yeah.
diabetic medication. I'm
Yeah.
in this, for some of the people who need it, who may be on the other end of the age spectrum.
Yep.
And so that's why there was advocacy on both the young adults, but also on the senior side.
Mhm.
Um, and young adults happened first, and then senior side. But it was notable that there was actually debate about,
Yeah.
like this is actually, like, should the young adult be the next step, or should it be like the folks that are 65 plus, or eventually 50 plus? I do
Right.
think that at the end of the day, there was a smaller, um, number of those folks, but they were in greater need. And I do
Yeah.
think that the fact that we had a pandemic that was particularly predatory for those
Mhm.
folks 50 and over
Mhm.
did help provide a strong argument for moving ahead with that population as well, and providing
Yeah.
that care, because it was the one that was so vulnerable during the
Yeah.
pandemic.
It provided a policy window
Yeah,
to be able to move that work forward. No, I agree.
absolutely.
Oh, go ahead. Go ahead.
No, no, I mean, I just think through this effort, there was a lot of efforts to spotlight the need for this coverage, and I think the pandemic did again provide. We saw the polling for the
Mhm.
support in the polling for this policy jump up significantly, because people recognize that
Yeah.
in many cases these are the folks that are the essential workers. These are the folks um, that are in our community,
Yeah.
and again, our health is interdependent on one
Yeah.
another. My kid in Davis, California, went to elementary school with the kids from the migrant camp,
Yeah.
and so when we expanded coverage, that meant that every child in every classroom and every
Yeah.
playground had access to affordable coverage, and that just didn't benefit those kids. That
Right.
benefited everybody in that classroom,
All of
everybody in that
us.
school, including
Yes.
my own. And so was that was a powerful moment when that finally passed, and I was able to see, like, oh, and that includes, like, those
Yeah.
classmates, those parents that I talk with at intercambio mornings,
Yeah.
with at the Spanish immersion school that he was at.
Yeah. And I think that's the power of population health, right? We're talking about all of us. When we raise up one community, we're raising up other communities as well. And I really like the point you shared earlier around the connection with health and our economy, right? It's a sound economic decision to keep people healthy. If we have a healthy population, that population will show up to school, will show up to work, right? And be able to continue to move the economy.
Yeah, economically, it is not good for the economy to have so many people with medical debt. It is
Mm-hmm.
not good for the
Mm.
economy to have people at risk of medical bankruptcy, which
Yeah.
continues to be a leading driver for bankruptcy. Medical bills continue to be a leading driver for bankruptcy.
Yeah.
It is uh, a a population that is more covered, is more economically secure, and
Mm-hmm.
allows for a more a vital economy. And I think there is research that is very clear, uh, that shows that very clearly. The work that we have. I also think that it also helps economically the health system, because again, these are the same
Mm-hmm.
hospitals, and if these folks are uninsured, maybe they get some care in the emergency room, but it actually is better for
Yeah.
that hospital that we all rely on if these folks are paying patients, and and if they actually can get primary and preventive care in the front end,
Yeah.
rather than emergency um, just emergency care in the back end, which is the most expensive, least
Mm-hmm.
efficient way to get
Mm-hmm.
care in our system. Um, this provides a system that provides more bang for the buck for everybody, and so I
Mm-hmm.
think that's an important piece that we've been wanting to make sure that people know, especially as we go forward to try to now also open up not just the Medicaid program, but the covered California and as our ACA marketplace.
Exactly. Exactly. And now, Anthony, I know that there is some news
Mhm.
in the air, and a lot of us are sad to see you go, but we're also very excited for you. Tell us about this move in your journey coming up with you transitioning from California to now a federal level position.
Yeah. So this summer, I'll be transitioning to be the new executive director of Families USA, which is the national healthcare consumer advocacy voice. Uh, t- it's in many ways a parallel organization to Health Access. What Health Access does at the state
Yeah.
capitol and the state agencies, Families USA does in Congress and
Right.
with the federal administration, and working with, and they're an organization that I've worked with for over a quarter century, both in New Jersey and in California, and have just a lot of just re- respect and admiration for their work, and to join them as their director
Hmm.
later this year is a high honor that I hope uh, to meet the challenge of.
Hmm.
I'm excited to take some of my experience
Yeah.
to this new role. It's after 22 years of being executive director of Health Access, I feel um, that it's time for another chapter and another way for me to make my
Mm.
contribution, and perhaps to be helpful and an added value and an added value supporter of the work that's going on across the country to
Yeah.
get us to a more universal and equitable and affordable health system. And Families USA is one of the preeminent places to do that work. Uh, Very aligned with what I've been doing in California, but obviously, with a with the broader mandate of trying to do it for the country. And I will say that it was a tough decision only
Mhm.
because I work with such a great community
Yeah.
of folks that here in California. But it's the same thing that makes it hard to leave is
Mhm.
also why I have confidence that I could leave,
Mm.
that the work will continue. I have a great team at Health Access,
Mm.
including a deputy director, Amanda McAllister Wellner, who will take over as interim as we do a nationwide search. But
That's great.
I, just also a great coalition community that will continue to do great work here in California, while I try to help provide that sort of federal framework
Yeah.
and hopefully financing to make continued progress in our effort to get that sort of health system for all, not just Californians but Americans.
Oh, thank you for sharing. And let me say congratulations. I think Families USA is so lucky to have you. And we're so excited to see you, putting that California leadership, that California mindset, right, at work at the federal level and bringing some of the solutions that we've been able to advance in the state now to that national lens.
Yeah, no, I want to be humble because I recognize that there's 49 other states that each have their own
Of course.
particular cultures and priorities
Yeah.
and processes. I know I'll get very little traction by saying, "Oh, this is the way we did it in California," but I do think that there is some experience and that I can provide some
Yeah.
uh, it's that there's lessons that I've learned. There's and just having a sense of, okay, I have the experiences and the scars to prove it,
Right.
that this work is hard,
Yeah.
and even in California, this work is hard, and
Yeah.
so maybe I could find a way to help some of my friends and colleagues in other states, who might be dealing with stuff that is even harder,
Yeah.
but but maybe with a perspective of being an advocate, being an organizer, being somebody who has worked on the ground, worked at the state level, can
Yeah.
provide that sort of framework for success, both in other states, but also nationally, even with the sort of very fragmented and sometimes even divisive
Yeah.
politics that we sometimes encounter at the national level.
Yeah.
I do think that there's an opportunity for moving forward on, on. I think that there is even a bipartisan interest in dealing with healthcare costs. I think that
Mhm.
there is
Mhm.
an interest in getting to a system that is more empowering and
Mm.
culturally competent rather than one that is so confusing and Kafkaesque in how people experience it.
Yeah.
And so uh, I'm looking forward to it, and um, and will take. But my time in California will always
Mm.
be special to me because of the progress we made, but because of the relationships that I've built as well.
Yeah, definitely. Now, Anthony, with these wins and the scars that you mentioned, right? What do you think, and this is the $1 million question, right? What do you think is left to do? How do we finally achieve health equity for our community?
Uh, again, I don't think it's one thing. I think we see. I think there's a lot of people who want to talk about broader things, but I think you start with, let's finish the job on coverage. That there's
Mm-hmm.
still work to do to make it accessible, to make it affordable, to
Mm-hmm.
make it administratively simple, if not automatic.
Mm-hmm.
And that's sort of a foundational piece of just getting people into the system. You can't it's hard to row a boat when people are hanging off the sides.
Right.
So like, yeah, so like getting folks, and let's not let up on like that core uh on one of those core goals. But it
Mm-hmm.
also is important that once people are in the system, that it's actually um affordable, that it
Right.
actually is culturally competent, that it actually provides quality care.
Yeah.
Right now, if you're getting care, it's actually a coins flip 50% chance that you're getting the
Mm-hmm.
right care at the right time,
Mm-hmm.
in the right way that actually achieves good outcomes.
Right.
And um and so there's a lot more to do to have the accountability of the system for better quality care, for the
Mm-hmm.
costs to be contained, for us to deal with the disparities
Mm-hmm.
between um, races and ethnicities and other communities, disparities between regions, rural, urban,
Mm-hmm.
disparities with regard to certain other social determinants of health. And how do you just deal with the diversity of California and America in a way that
Yeah.
respects um, people and empowers them when they engage in the health system? And so I think there's a lot more to do to have those systems of accountability for the
Mm-hmm.
industry. I think
Mm-hmm.
you know we're we're starting to put in place some of those things here in California with
Mm-hmm.
better contract provisions at the Department of Healthcare Services and Medi-Cal, or at the Department of
Mm-hmm.
Managed Healthcare or Covered California with regard to even private coverage, on to have better metrics and agreed upon metrics across
Right.
platforms
Yeah.
on quality and equity. I think we're doing more to have some broader accountability, with the creation of the new Office of Healthcare Affordability.
Mm-hmm.
And but there's a lot more to do to get to the point where, oh yes, the financial incentives of our system are aligned toward actually provide for actually getting better, not
Yeah.
just getting bigger, which
Right.
is right now where the incentives mostly are, is just getting
Right.
bigger so that you can demand a higher price. And
Right.
that's and so how do we get to greater equity? Let's continue to do the work to not just get everybody in, but to change the financial incentives and accountability structures so that the incentives are aligned toward quality, equity, affordability, and ultimately better health for everybody.
I love
And
that.
and we need to do that through both universal means, universal
Mm-hmm. Mm-hmm.
broad-based policies,
Mm-hmm.
and specific policies that deal with the specific needs of specific communities.
Yes.
The universal solution needs to happen to change some of the power dynamics, but we
Mm-hmm.
also need to deal with specific uh, uh, the specific issues that specific communities have, or we're not going to uplift all boats, and so we
Yeah.
need to do all of it.
With that
So
in.
it's not we're not going to be out of a job anytime soon, but I believe that it will be a fun process while we do it.
I would agree. Moving forward with that intentionality. Well, thank you so much for your time today. We really appreciate your thoughts, your wisdom, and we just appreciate having this conversation today. Thank you for joining us.
Thank you, Cecia. It's been a pleasure.